me. I feel very honored to have been asked to present at the Grand Rounds. I've been learning so much every single month from attending, and I feel like it's definitely teaching me so much to become an even better clinician. So thank you so much for asking. Just a little bit about myself and how I became interested in sleep. So I think in 2007, I attended a conference where I learned about the, oops, I'm just gonna admit somebody real quick. Where I learned about the prevalence of undiagnosed sleep disorders in children with ADHD. I work with children, adolescents, and adults in my practice. And so at the time I was doing quite a few ADHD assessments as well as treatment for ADHD, and learning that, I felt, oh my gosh, I really need to know more about this. So I started digging into conferences where I could go to like a pediatric sleep disorder conference. And I came across, there was one, but it wasn't for quite some time, but I came across one in Virginia on CBTI, and it was being hosted by Dr. Michael Perlis and Dr. Don Posner, who I have the utmost respect for both of them. And so I attended the 3-day conference and learned so much. I was totally hooked after that, especially at looking at the impact it has on helping people with depression and insomnia. And so after that conference, I think there's just a few people in the waiting room. Let me just admit them. Okay. Whoops. So after attending that conference, I had my first 5 or 10 cases of CBTI clients supervised one-on-one with Dr. Don Perlis, who is a fantastic, very well-known sleep psychologist, and taught me so much about CBTI and doing a good job with that. So that was really what got me geared into sleep as a psychologist. And then I moved to Canada in 2011, and I because the sleep world is it's large yet small, I started reaching out to a few people, and actually Dr. Awad was the first person that I reached out to because I live in Burlington. And then the second person I reached out to was Dr. Shapiro. So I feel like it's like full circle all of a sudden. Seeing him last month was great. And I feel like, I learned so much from both he and Dr. Awad, and I've continued to cross-refer ever since. So that's been just a great intro into sleep in Canada. So now I work in Happy Mind Psychology, my private practice, as well as at Peak Sleep. And I see children, adolescents, and adults, and a lot of children with sleep disorders as well. But with Peak Sleep, my primary interest is in CBTI. So let's talk about CBTI and get going. So what is chronic insomnia? As you all are very well aware, it's a problem with initiating and maintaining sleep. My clients mostly have difficulty falling asleep, staying asleep, or waking too early, at least 30 minutes or more, 3 times a week for at least 3 months. Plus, they have some sort of daytime consequences as a result. And as you know, every person is different. Every person's insomnia is different. Some people have it at the beginning of the night, some people have it at the end of the night, some people have it in the middle, and other people have it all over the night. So the most common daytime consequences we see are consequences of mood, people feeling more sad, more stressed, more irritable from sleep loss, or cognitive issues, difficulty focusing and concentrating, feeling less productive, and difficulty with fatigue or just general loss of energy. So it's quite prevalent. Insomnia is the most frequently occurring sleep disorder in the adult population. 15 to 20% of the population have primary insomnia. That's just insomnia kind of purely on its own. But a very large number of people with psychiatric disorders also have comorbid insomnia. So I truly feel like this is enough data to suggest that really every sleep clinic should have a psychologist or some mental health professional there. As well, every psychologist and I feel a clinician should really be trained in CBTI because we see so much depression and other psychiatric disorders. But then also the co-occurring other sleep disorders category is also, really important to look at, because we do often see both, like Dr. Howard Awad was just saying, with the co-occurring sleep apnea and chronic insomnia. Not everyone with apnea has insomnia, but those that do, we really have two things we have to get at there. Otherwise, I think their untreated apnea will really deter their treatment for getting the insomnia under control. So why treat insomnia? Well, one thing we know is that it's persistent. Most people that have chronic insomnia will still report having it 1 year later, and over half of those people will still have it 3 years later. So we know that it really doesn't go away. It doesn't just vanish one day without proper treatment. It also increases our risk for other medical problems and depression and recurrence of depression. And of course, the long-term use of sleeping pills. As Dr. Shapiro was just saying last month, we know now we have to think differently about insomnia. We used to think that we can treat the depression or the underlying anxiety disorder and the insomnia will go away. And that's just not the case. It kind of becomes its own beast and requires its own treatment. And it's really not enough to just treat the depression or anxiety. And one of the most exciting facts to me is that when you have a depressed client and you use CBTI to help them with their insomnia, you can actually teach them the skills they need to prevent a recurrence of their depression. So if usually return of sleep problems is the first sign that a depressive episode is coming back on again. And you can kind of see that their sleep gets messed up. Then they have less energy, they stop going out, they start isolating more, they start feeling more lonely, maybe not getting out of bed very often, sleeping all day. And then bam, they have a whole nother recurrence of a depressive episode. So if you treat the depression and the insomnia, can actually prevent a recurrence of insomnia. And then if the sleep problems return, they know what to do to ward them off after for relapse prevention. And to me, that's huge. So why treat insomnia with CBTI versus sleeping pills? This is the golden question. Well, it's extremely effective. I'm going to thank Dr. Perlis for sharing a few slides with me. Over the past 20 years, there have been some huge meta-analyses that are all really pointing towards the fact that it's very effective in the treatment of chronic insomnia. It's also more widely accepted by patients. I think it's easy to say here, take the sleeping pill, take this every night, you'll probably sleep better. But I think more people would rather have the opportunity to try a behavioral treatment before starting to take a medication every day. They also have obviously expected fewer side effects from taking or from using CBTI than taking a sleeping pill as well. And they're even more willing to comply. CBTI also works as well or better than hypnotics in the short term. Here you can see SL is sleep latency, NA is number of awakenings, WASO is waking after sleep onset, and TST is total sleep time. As you can see, it helps a lot with falling asleep, initiating sleep, and maintaining sleep. Those effect sizes are huge. Moderate effect sizes are 0.50. So you can see that these are really big effect sizes when compared to hypnotics. The only time we're kind of coming up short is with total sleep time. We're going to talk more about that later, because actually that may be artificially a little low, because we actually restrict sleep during CBTI. And so as a function, you're not going to see huge gains in total sleep time until maybe even, a few weeks post-treatment. CBTI also works better than meds in the long term. Here, if you look at the short term, long term, and hypnotics in the orange, you can see that in the short term, it's better for sleep latency, and then it continues to get even better in the long term. Again, total sleep time still a little bit lower than you would get with a sleeping pill, but their overall sleep quality is much better. They're going to be sleeping much more efficiently and having less difficulty falling asleep and staying asleep. Even though their total sleep time might not be 8.5 hours, I always tell people 6 hours of solid sleep is way better than 8 hours of broken sleep. And if you've ever had a baby, you know that that fact is true, because the first night that they sleep 4 straight hours, you feel like you could run a marathon the next day. So in a lot of the meta-analyses and a lot of the short-term and long-term studies, they look at like 8 and 12 weeks of treatment. So they decided to go in and cut it at the 4th treatment session just to see the effect size at the 4th session. And actually, you're already getting a lot of effects by the 4th session. The manualized approaches to CBTI will usually suggest about 6 to 8 visits. But in my experience, I find they know everything I know. They know everything that I'm teaching you in this talk tonight at about the 5th session. We don't have much else to say. It's just like they don't need to pay me to be their cheerleader and score their diary. I can teach them how to score their own diary and be their cheerleader from a distance if they want to reach out to me later and tell me how great they're continuing to sleep. But I feel it's better to just put it all in there and follow them for those first 5 sessions. And I feel like they're doing really well at that point. And this research really backs up that feeling. So Dr. Perlis also shared the next 2 slides with me. And that is that CBTI is not only good just for pure primary insomnia, it's also very efficacious for secondary insomnia, which is insomnia comorbid with other psychiatric disorders. And you can see this long list. I'm sure this is not even a comprehensive list to date, but there have been several studies that suggest it's effective even when they have other psychiatric disorders and medical issues. So in summary, CBTI is effective in treating chronic insomnia. It is as effective as hypnotics in the short term and even more efficacious in the long term. 60% roughly have a good treatment response. And of those, 65% attain remission after treatment has been discontinued. And it can be used for primary and secondary insomnia. So what is CBTI? So what I'm going to do is run through from session 1 to session 5. I want to give you an overview of what CBTI is. Although this is a little bit of a different approach for me, I'm not usually doing presentations on CBTI on a regular basis, except for one-on-one with my clients. So usually what I'm going to be showing you in a graph form on my screen is a very interactive, illustrative process with the client where I literally draw out the graph bar by bar with them one at a time while we're interacting. So this is just a little bit different. So I just hope that you can all understand very well. Okay, so bottom line, a lot of people come to me and they say, oh, I've had, well, not a lot, but some people come to me and they say, I've had CBTI and it didn't work. And then I ask more about the treatment that they had, and I'm not really sure if it was CBTI. So clinicians are not really scoring weekly sleep diaries using stimulus control, sleep restriction, and tons of acronyms such as the following, then it's probably not CBTI. The goal of CBTI, I was thinking about this as well, it's really to teach the client how not to get in the way of the natural process of sleep, how to consolidate their sleep to more easily initiate and maintain sleep, and really increasing total sleep time is a secondary game that will come in time. So session one is really a clinical sleep assessment. I dive into asking them all about when their insomnia started, what are they currently experiencing, what's their current bedtime, their wake time, how long does it take them to fall asleep, this is their perception, how many times do they wake up at night, how long are they up during those times, do they have early morning wakenings, what's their total sleep time, what's a good night for them, what's a bad night for them. I want to know how it's affecting their daytime functioning. And then I'm going to start asking more questions about what they do when they can't sleep. These questions are geared toward me looking for clues as to what the factors are that have been contributing to their insomnia. We're going to go into all the factors that, take insomnia from acute to chronic in just a minute, but this is where I start gathering my information and kind of like Sherlock Holmes, I'm looking for those perpetuating factors. I'm looking for those things that they've been doing that's probably maintaining their insomnia so that I can help them understand that in the next session. I'm also looking at daily habits, when they have their last cup of coffee, how much alcohol they drink, do they exercise each day, are they trying cannabis? Talking about the sleep environment as well. I want to know if they have pets in their bed, if they sleep with their significant other, or if they sleep in a different room. Do they have blackout curtains? Are they a light sleeper? Do they sleep in a cool room or a hot room? How's their bed and pillow and everything? We're looking for all of this just to screen for sleep hygiene. And I give them a dysfunctional beliefs and attitudes about sleep questionnaire. And we screen for all mental health disorders as well, just to see if they have primary or secondary insomnia. But the most important part of the end of this session is giving them their sleep diary, their first copy, telling them that I need them to keep this every single day until their next appointment so that we can establish a baseline. Because just telling me off the top of their head how they sleep from night to night, and they often say, well, it varies from night to night. I can never predict if I'm going to have a good night's sleep or a bad night's sleep. I say, well, I need the data and I need to be able to score it so we can go from there. So this is the example of the sleep diary I use. This is the one that was shared with me by Dr. Perlis and Dr. Posner, and I feel like it's the most beneficial for CBTI. So you can see the first section they complete before bed. I want to know the date, unusual daytime stressors, if they took a nap and how long, if they took any sleep meds or drank any alcohol, and then the time they went to bed and turned the lights out. Then, so that takes about 20 seconds, I tell them. And then in the morning, you're going to complete the next 5 blocks. You're going to tell me how long you think it took you to fall asleep. All of this without watching the clock, by the way. I tell them, do not be a clock watcher, put the clock under the bed. But I want to know how long it took you to fall asleep in the morning, how many times did you wake up and return to sleep? How long do you think you were awake during those times? And what time did you wake up for good? And what time was your alarm set for? And then everything else, I tell them to leave blank, that's for me. So there's an example down at the bottom as well, so that if they forget how to complete the diary, they can always refer down for assistance. Session 2. So I feel like session 2 is probably the most important session of everything. This is a hugely educational session. At this point, we've established the baseline. In this session, we established the baseline where I get the 2-week average of their sleep latency, the average amount of time it takes them to fall asleep, how long they're awake in the middle of the night, how early they wake up, how much time are they spending in bed for their desired sleep time, and how much time are they actually sleeping for the final measure of sleep efficiency. So in this session, I'm going to introduce you as well to the Spielman model of chronic insomnia. We want to make sure that the client really understands how their insomnia went from acute to chronic. So we walk through all of the factors that contribute to the development of their insomnia, and that's exactly where we teach them what we're going to do to undo the problem. So we introduce in this session stimulus control, the rationale behind sleep restriction, and we set their bedtime and wake time for the first week based on their baseline. So this is the Spielman model of chronic insomnia. Spielman identified that, we go from acute to chronic with three main factors: predisposing factors, which are the factors that predispose one person over another for the development of chronic insomnia, maybe just age or tendency towards being a little bit of a worrier, things like that. And then goes into the precipitating event and then the perpetuating factors. The perpetuating factors, as you can see, are the things keeping them above that threshold. So I'm kind of going through this quickly because it's not really the one that we draw out for the clients in CBTI. We go more with this one. It is the modified Spielman, but all we do is we take the perpetuating factors and we divide them into two categories: perpetuating and the conditioned hyperarousal category as well. Also, this offers the client to see across the timeline at the bottom where they were before their insomnia developed, where they are now when they're coming into treatment under chronic, and then what we're going to be targeting for treatment and where they're going to be after treatment. So this is the bar graph I draw out in the second session with every single client. So we're going to walk through these factors with this graph. So let's talk about the first factor. So the first factor are those predisposing factors. These are kind of personal biological factors that predispose some more than others for the development of insomnia. Age, anxious temperament, personality, they may have pain or a history of trauma. These are things that may predispose someone to having sleep problems. And so what I do is I draw this blue bar going across, all equal pretty much across the bottom. And I say, so I want you to think of this as like a rung in the ladder that's bringing you closer to this threshold. This is the threshold between insomnia and normal sleep. So I tell them everything above this threshold is insomnia, or 30 minutes or more to fall asleep, stay asleep, or wake too early. Everything underneath this threshold is considered normal sleep, or less than 30 minutes to fall asleep, stay asleep, or wake too early, which is totally normal. So if you can think of each of these bars as kind of a rung in the ladder, getting you closer to this threshold. Okay, so then that brings us to the second factor, the precipitating factor, or the stressful event, if you will, the trigger. Stress is usually, it can be positive or negative. This could be, a job promotion that makes you anxious and you lose a little sleep. It could be a wedding, it could be the birth of a baby, or it could be the loss of a job, death in the family, or something more, a medical diagnosis of some sort. So I tell the client, you're going along living your life and all of a sudden some sort of stressful event occurs, positive or negative, and you lose 1 to 2 nights or 1 to 2 weeks or even 1 to 2 months of sleep in response to this. And I explain to them that this is totally normal because this is acute insomnia and that all humans have acute insomnia from time to time, even me. And that there's nothing that will cure you of a bad night here or there. But obviously, it's continued for you. And so that's something we're going to work on. But as you can see here, stress gets us up over that threshold, but then we're adaptive. As you can see, over time, the stress is no longer enough. We've either found a solution to our problem, the problem has passed, the event is over, or we've adjusted or adapted to whatever that stressful event was. Maybe we've sought treatment or whatnot, but it's no longer enough to account for all the variance in your sleep. You can see it's going down over time. And so that brings us to the third factor. So the perpetuating factor. So what I tell people is, so sleep scientists have studied people with chronic insomnia, and we found that they do a lot of the same behaviors around sleep. They have a lot of the same reactions to sleep loss. And so these are what we call the perpetuating factors. These are things you're doing to try and help your situation, but it's actually unintentionally making your sleep problems worse. So we look at that little block in the graph and we talk about what those things are. So this is the part that's very interactive with the client. And I say, so give me an example. Let me give you an example. Let's say last night you slept really bad. If you don't have to go to work right away this morning, what might you do this morning? And they say, sleep in. Right. So I write that down. And if you can't sleep in, what might you do later in the day? Take a nap. Exactly. And if you don't have the luxury of sleeping in or napping, what might you do that night? Go to bed early. Yes, absolutely. Try to make up for some of that sleep loss. And what about exercise? Do you think you would exercise that day if you slept really bad last night? Definitely not. You're probably going to cancel going to the gym and not be as active. And then what about social plans? Do you think you'll keep your social plans, or are you more likely to cancel those? I'm definitely probably not going to go to that party if, I had plans. I might cancel. So I discuss with them how this is not all the perpetuating factors, but I just pause for a moment and I say, okay, all of these, I just want to pause for a minute and talk about how these have something in common. All of these have a tendency to reduce your homeostatic pressure for sleep. And they say, well, what's that? And I say, well, that's the pressure that builds in your brain from the time you wake up in the morning to the time you go to bed at night. And you need a certain amount of that, not only to induce sleep, but to maintain sleep all the way to the morning. Well, when you sleep in, say last night was bad, but you sleep in today, guess what? You've just let out a little sleep pressure for tonight. If you nap, same thing. You're letting out a little bit of that pressure that you need. And if you go to bed early, you might have enough pressure to fall asleep, but you probably don't have enough pressure now to stay asleep. By going to bed at 8 o'clock, you're not going to be able to sleep till 7. Likewise, especially during COVID, I've seen so many people are so much less active than they usually are, just from this, not even purposeful activity, but just the walking to their car, going to the GO train, getting on the subway, getting on the streetcar, going out for lunch, walking in their building. All of this activity has been reduced since people are working at home. But in addition, not going to the gym reduces your activity level as well. So we talk about all of these have that in common. They really mess with your homeostatic pressure for sleep. And then it occurs again and again, and you can't seem to shake the problem. Well, what are the other perpetuating factors? A lot of people start to drink more caffeine or alcohol in response to their sleep problem. They may be drinking excessive amounts of caffeine or drinking it much closer to bedtime or later in the afternoon. I had a client that was using a lot of vitamin B to give her a pick-me-up, but it was kind of acting like a caffeine boost at night and making her sleep problem worse. Some people drink alcohol to induce sleep as a hypnotic or as a sedative, and how to calm themselves down as well. But we know that alcohol interrupts sleep later, so I educate the clients about that too. People start bringing all kinds of activities into the bed too when they've been having sleep problems. They just want to rest there. They just want the comfort. I think they're going for self-compassion maybe, but it turns out to be a perpetuating factor as well. So these are things people do when they can't sleep in the middle of the night, as well as just during the day. They start hanging out in their bed a lot of times more often. So at night, we might see people turn on the TV if they can't sleep, start reading 3-4 chapters of their book, playing on their phone, bringing their computer in. Clock watching is another thing that really increases anxiety, because they start continuing to see the night hours slipping away and start feeling more and more anxious about what's going to happen tomorrow as a result. Oftentimes, I tell them, and if you're not doing any of this, if you've gotten online and you've looked up what to do if you have insomnia, all of this is going to be really on the internet. It's going to say, don't do any of these. Make sure you go to bed at the same time, blah, blah, blah. But the number one activity I tell them that most of my clients do that they don't even realize is an activity is lie there in bed night after night awake. Because most of the time when you're lying awake in the bed, you're not in a Zen state. You're usually having some big emotions. You're feeling irritated, you're feeling anxious, frustrated with the fact that you cannot sleep. So we're having this bed awake, bed anxious, bed awake, bed anxious, bed awake, bed anxious. So we have all this pairing happening, which leads us to the fourth factor. So we've got the perpetuating factor obviously right here, but then you can see what starts to develop on top is this Pavlovian conditioning. And I think Dr. Perlis used Pavlovian conditioning because he was trying to make it the 4P model as opposed to the 3P model, but you can also think of it as conditioned hyperarousal. So I explained to them, bed, awake, you're in bed every night, awake, anxious, having fight or flight, you know, your autonomic nervous system is going, can't sleep, frustrated, and that leads us to the fourth factor. So at this point, and this is actually in the CBTI training, you can pick your own story, but I go into, well, before we talk about the fourth factor, I want to tell you a little story. So before I was married, I was single. I would come home from work every night. I would make my dinner and sit on the couch. So I'd sit on the couch and eat my dinner night after night. Dinner, couch, dinner, couch, dinner, couch, eating couch, eating couch, eating couch. And then one day I went out for lunch with some friends, ate a huge Mexican feast, came in, I was so full. I sat on my couch, and what did I want? Food. And they say food. And I say, yes. Well, why do you think I wanted food? Well, because you had associated it. That's right. So what do you think I had to do to undo that? Well, stop eating on the couch. Exactly. So I still didn't want to sit at the dining room table by myself because that was just weird. So I was like, oh, I'll just sit at the bar in my kitchen because I don't really sit there for any other reason. And I'll eat my dinner at the bar. So I would sit at the bar and eat, and then I would go back to the couch. And I said, so do you think the very first night that I did this, I no longer wanted food on the couch? And they said, well, no, probably took you a little longer than that. How long do you think it took me? Maybe like 3-4 weeks. Exactly. So I'd have to go to the couch and not eat there. And then if I felt like eating, I need to go somewhere else and eat it. And then sometimes I'd have to realize, yeah, that's just an urge to eat, but I'm not hungry at all. And so this is exactly what happened with your insomnia. You paired the bed with being awake so many times and the bed with being anxious and lots of other activities, the TV, the books, the everything, to the point now that your brain is actually conditioned to be awake in the bed. So this is the thing that we need to unpair. And so now you know how your insomnia came to be, and we're going to talk about what we're going to do to fix it. So again, you can see the perpetuating factors is what we're going to be targeting. So I crossed out that green block and I say we're going to knock this out with stimulus control, which is going to control for all those perpetuating factors you were doing before. And then that pink bar is going to take about, 3 to 4 weeks to come down, but eventually the paired conditioning will go away with the help of stimulus control and sleep restriction. All right. So what does treatment look like? So part 1 of treatment is controlling for all those perpetuating factors with stimulus control and sleep hygiene. So what is that? These are the rules Bootson created around stimulus control, really wanting us to train the brain. The bed is where we sleep. Do nothing else there. The bed is where we sleep. And we want really to have a solid conditioned experience to turning off associated with the bed. Okay, so I combine sleep hygiene with stimulus control in my treatment with clients, and I feel this is the better way to do it. You can do it later if you want. I mean, but I feel like stimulus control, sleep hygiene is really the confounding variable. If they're doing everything they're supposed to and they still have this bright window and the lights coming in, or they're sleeping with their dog, these are confounding variables that are going to interfere with treatment. And I remember I was treating a little girl and she would wake up at the same time every night. And then we realized that the neighbor had a Harley Davidson and that was waking her. And that was why every night at the same exact time she was waking up. So just making sure that you have a cool, dark, and quiet bedroom to start is really ideal. I teach them about having a buffer between work and sleep, having a regular wind down routine, and then most especially in CBTI, I tell them you're going to have to keep the same bedtime. even on weekends. And you're going to have to keep the same wake time that we prescribe you, even on weekends. You have to set your alarm, even if you're not working, and even on weekends. Don't clock watch, so turn the clock around, but make sure you set your alarm. Don't go to bed early, and don't sleep in. So it's kind of harsh. No naps, I say, of course, unless you're sick or something. And the bed is for sleep and sex only. We really just want it to be associated only for that. Be active each day. Try to get exercise. That will build your pressure, and they kind of start to understand how the more pressure, the better. Be social, cancel nothing. This rule really comes from the fact that if you allow them to cancel things, it almost puts too much pressure on their sleep. If you're thinking, I can't go to my niece's baptism tomorrow if I sleep well, now you've added a whole lot more pressure to having to sleep tonight than you would have if you said, I'm going to the baptism no matter what. Like, nothing's getting in my way. I'm not letting sleep rule my life. So this is really good for people with depression too. Just cancel nothing based on sleep. Make sure you keep your life. Minimal alcohol after 7 p.m. Stay hydrated, limit caffeine 7 hours before bed. And of course, most importantly, don't work, hang out, watch TV, or read excessively in bed. If people have to read at bedtime, I like to read a little bit at bedtime, but it's like a 10-minute max. I fall asleep after the first page. So I tell them 10 minutes is the maximum amount. Anything more than that is an activity. And if you can't sleep after 20 minutes, or you're starting to get restless, or if you're anxious at all, you want to get up and get out of bed. It's just like me getting off my couch to eat. You know, this is probably the hardest thing for people, definitely, hands down. But I tell them the better you can be with this, the more likely you are to get the results. So if they can't sleep, you know, you get to that point, they're like, well, what do I do? I can't watch the clock. How do I know if it's been 20 minutes? I say, just know that if you're feeling it's not happening, just get up and take a little break from the bed. Reset. I call it a reset period. Well, how long should I stay up? Well, some people like to stay up till they feel sleepy. Other people aren't a good judge of when they're sleepy. So I just tell them to get up for like 15 minutes, 10 minutes, 20 minutes, just something just to get out of the bed. But the shorter the interval, the more times you might be getting up. So you might want to just stay up for 20, 30 minutes, then come back and try again. Now, try again, meaning don't try to sleep, but just come back and see if sleep is ready. So that's part one. Part one is making sure they really stick with their bedtime, their wake time, and follow all the rules for stimulus control and have good sleep hygiene. Part two is about maximizing their homeostatic pressure for sleep with sleep restriction. So what does this do? This really, we're trying to have positive conditioning associated sleep in the bed, sleep in the bed, sleep in the bed. So we want to increase their sleep pressure so that they're more likely to associate the bed with falling asleep quickly. So this is when I draw this out for them and I say, okay, so this is the rationale for sleep restriction. I draw the first line at the top and I say, okay, so let's say I graphed your baseline. I graph every night your desired sleep time, the amount of time you're in your bed across all 14 nights. The line would look something like this. You know, you're shooting for a little bit more than 8 hours. Those are minutes down the left side. And then I would draw the second line, the darker blue line, and I would say, now this line represents your sleepability. And so what's the problem here between these lines? And they say, well, there's a big gap. And I'm, exactly. So what do we want these lines to look like? And they say, well, much closer together. Exactly. So if I could, I would just go in your brain and increase your sleepability. That would be excellent. But unfortunately, I have no way of doing that. So what we're going to do to start is we're going to reduce your sleep opportunity to match your current sleepability. And then we're going to take baby steps back up, increasing your sleep opportunity, hopefully every week until we get you an increased total sleep time. But the first thing we're going to do is match your sleep opportunity to your current sleepability. So in this case, say the person was trying to get 8 hours, but they're only actually able to get close to 6. we would restrict their sleep to 6 hours plus the 30 minutes that it takes the average person to fall asleep. And then we would work with them on setting their bedtime and their wake time. I don't like to be the decider of that. I think they're much more likely to be compliant when they get to kind of pick. Some people want to be a night owl and sleep later. Other people would rather go to bed earlier and wake up really early. So for example, if it was 6.5 hours, I said, well, we're going to be restricting you to 6.5 hours for the next week till I see you again. You can decide. They might choose from go to bed at 12 and wake up at 6:30 as an example. Okay, so that's session 1 and session 2. To me, 2 of the most important sessions. After this, we're really using the first part of every session to look at their sleep diary. I score it. I follow up on if they've been compliant with stimulus control, and I can see from the sleep diary how compliant they've been with their bedtime and wake time. So that's really important. We also titrate their sleep, and I'm going to get into that in another slide, which means like either moving the bedtime forward or backward, depending on their progress for that week. And then we use the rest of the time, which is probably the last half hour of the session, just doing any cognitive work that they might need or sleep education. So in titrating their sleep, what we're looking at is always the sleep efficiency. If their sleep efficiency is more than 85%, so they've got 86, 87% sleep efficiency, I'm going to give them more sleep. So I'm going to let them go to bed the next week at 11:45 or 11:30 as opposed to midnight. If their sleep efficiency for the week on average is somewhere between 80 and 85%, I'm going to hold them at 12 to 6:30 for another week. And they're just going to have to bear with me. If their sleep efficiency is still really low and less than 80%, and I feel like they can handle it, we may make them go to bed closer to 12:15 or 12:30 and restrict their sleep even more to add that pressure and consolidate the sleep as good as we can. Then we're going to use the time to do individualized cognitive work. And what is this? You know, this can really be anything depending on the client's needs. It really depends on what they are presenting with. And I think that comes maybe with being more of a experienced clinician, that I'm not just going to say, let's talk about your sleep-related cognitions. If they have other things that are keeping them up at night, we might dive into that. But traditionally, we do cognitive restructuring, identifying any sleep-related worries, catastrophic thoughts about losing sleep. We talk about sleep education and the stages of sleep, that it's normal to wake up a couple times a night as long as you get back to sleep easily. We talk about how if you wake up in a deep stage of sleep, you may have a lot of sleep inertia and feel really tired at first. That doesn't mean you had a bad night, things like that. Debunking sleep myths. We may do the odds game, which I'm going to go over in just a minute. Talk about relaxation training skills, things they can do to relax their mind and body with breathing and progressive muscle relaxation, and even kind of unhooking skills for sort of unhooking for their thoughts and noticing their thoughts, but not getting as upset by them. Examples of sleep worries and catastrophic thoughts that we often do see: what if I can't sleep tonight? What if I lose my temper with my kids tomorrow? What if I mess up at work tomorrow? What if I feel awful tomorrow? What if I get in an argument with my spouse because I sleep poorly? What if I get sick? And then more catastrophic thoughts, I will not be able to function tomorrow. I will get into an accident and kill someone. I will die. I will go crazy. I will get fired. So here's an example of cognitive restructuring. So this patient's thought was, I will not be able to sleep at all tonight, and tomorrow I will not be able to function. First of all, I just have to say that word function comes up so often, and I often have to help them understand the difference between functioning and not functioning. It's not so black and white, but you might not be on your A game. You might not be at 100%, but if you made it to your appointment, you showed up here in one piece, looks like you took a shower this morning, you are definitely functioning. So we kind of make a joke of that, and they're able to see that that is kind of catastrophic to think about that way. But so, for example, I might ask them, so how many nights have you had insomnia? Well, I've had it 5 years. How many times a week? Okay, say 4 times per week. Okay, so that is about 1,000 nights. How often have you had this thought? 3 to 4 times per week. I always have it. And how true does it feel to you? Like it feels really true at like an 8. And what feelings does it bring up when you have this thought? Oh, I just feel anxious and panicky at like a 9. And how many nights have you actually had 0 sleep? Okay, maybe only a couple. All right, so then we calculate the probability and help them to see that it's actually really low likelihood. Like the likelihood that you're gonna be up all night is very, very low compared to the number of nights that you've had insomnia. And even when you didn't sleep, could you function? Well, yes, but not my best. Okay, so what have you learned? And then the client may say something like, well, it's maybe highly unlikely that I'll stay up the entire night. And even if I do, I can still function the next day. Relaxation training skills, we might go into the brain and the amygdala, caveman brain, just trying to keep you safe, trying to help you predict what's going to happen so that, you know, you can function at your best. But the caveman brain is often wrong and quite negative. We do a little CBT for anxiety and do fear plans for their worries. What if I'm late to work? Or what if I yell at my kids? Well, what can you do? You know, I can apologize. I can, you know, talk to them. I can explain that my sleep problems just making me kind of irritable, things like that. Circadian rhythm education, sometimes just getting them out there in the sun in the morning and talking about how their brain knows how to sleep. Even fruit flies sleep. So you can sleep. You haven't lost your ability to sleep. This is a natural rhythm embedded in your DNA. So just making sure that you're getting that morning sunlight will help to also release a natural secretion of melatonin a few hours before bed, dim lighting in the evening, things like that. Teaching the breathing exercises, controlled deep breathing and progressive muscle relaxation does really help clients that are just really uptight in the bed, just to really start associating more of a relaxation feeling with their bed. Debunking myths, Colleen Carney's book, Quiet Your Mind and Get to Sleep, is excellent. And she talks a lot about these myths. So I often share these myths with clients and help to correct them. That 8 hours is an average. It's not a magic number. The more they feel it's a magic number, the more they get anxious about seeing the clock changing through the night. I should always wake up feeling refreshed and full of energy every morning if I slept well. Well, depending on the stage that you wake up, you may not feel well rested, but it doesn't mean you didn't get adequate and deep sleep through the night. Talking about a lot of clients think that insomnia is a chemical imbalance, and they feel that sleeping pills are somehow treating that chemical imbalance. So we sort of give them some education on sleeping pills don't really act like that. They don't work that way. Sometimes people feel insomnia is just a part of aging and there's nothing I can do to help my situation. And that even if I wake up a few times a night, this is not normal. So we help them to see that the average person actually wakes up maybe 12 times a night. Most of them just don't remember waking up. So a couple of cases that I just pulled to share with you. The first one is more recent. So this is a married mother, female. She's a nurse. She has a history of generalized anxiety disorder. She generally works in one unit, but since COVID, she was moved to a new unit. She's going to be working closely with COVID patients, and this has really ramped up her anxiety, and her insomnia is definitely out of control. Some of her perpetuating factors: she goes to bed very early just to maximize her sleep. She watches TV and reads in bed for about 90 minutes before turning the light out. She's stopped exercising. She never gets up when she's awake at night. She lays in bed most of the night. She sometimes even breaks down and takes a sleeping pill once she kind of gives up and feels like there's no hope in getting to sleep that night, which makes her feel way worse the next day. And she gets very anxious if not in bed by 9 o'clock. If she comes home and it's late, she tries to go right to bed just to maximize that sleep. Two of her main catastrophic thoughts were, I will not be able to function at work, and if I don't sleep, I will get COVID. So at her baseline, it was taking her almost 2 hours to fall asleep. She was waking in the middle of the night for about 20 minutes, and she was waking early by her alarm by 10 minutes. She was in bed for about 8.7 hours, and she was getting about 6.5 hours for a sleep efficiency of 75%. And then by session 5, she was going to bed at 11:30 and waking up at 7. She was taking 6 minutes to fall asleep, only waking in the middle of the night, on average 12 minutes. Early morning awakenings, again, still 10 minutes, but that's well under the 30-minute threshold. She was shooting for 7.3 hours, and she was getting 6.8 for a 93% sleep efficiency, and that's success. 2 weeks later, she was sleeping 11:30 to 8 by managing her own diaries and titrating her sleep backward. So the next case is a retired dad. He was 57 years old. He's a father of 3. He worked in pharma with lots of travel overseas. He'd been taking Zopiclone for 10 years with insomnia for 20 years. Feels he can't turn his mind off at night, wants to stop sleeping pills because he's been binge eating in the middle of the night and trading stocks in the middle of the night and doesn't remember any of it once he takes his sleeping pill. He would wake up and find all of this open food and eaten food in his kitchen, but didn't remember it at all. Predisposing factors, he tends to be a worrier. He worries about a lot of different things. And perpetuating factors, he often tries to drink scotch to fall asleep. He drinks lots of coffee throughout the day. He reads the news on his phone in bed. When he wakes up in the morning and he can't fall back asleep, he lays in bed and reads the news on his phone. And he drinks scotch when he wakes after sleep onset, often does not set his alarm, and mostly lies in bed awake. His biggest cognitive work was around, if I don't fall asleep right away, it's going to be a bad night, and just deciding that from the get-go. And if I wake up after 4 a.m., I will not be able to fall back asleep. If I wake up before 4 a.m., I will be able to fall asleep. So he sort of had this rule in his mind that we had to work on. And his sleep data took him a little time to fall asleep. He didn't really wake up in the middle of the night much, but he would wake up about 2 hours before his alarm. He was spending about 9 hours in bed from the time he went to sleep to the time he got out in the morning, and he was getting about 6.5 hours. Sleep efficiency was 72%. If you look at session 5, he was going to bed at 11:45, waking up at 7. His sleep latency was under 30 minutes. Waking after sleep onset was good too. And his early morning awakenings was down to 2 minutes. He was really sleeping right up to the alarm. But as you can see, his total sleep time actually didn't change at all, but he was sleeping much more efficiently. So he graduated with me at that point, but was given instructions on how to titrate his own bedtime and wake time going forward so that we could increase his total sleep time and he could maintain his gains for the next 4 to 6 weeks. So I just received this. This is for you, Dr. Watt, because I just received this email from a client yesterday, so I had to put it in here. She said, just wanted to wish you happy holidays, give you a sincere thank you for your help. I've been sleeping solidly since we completed our sessions and could even sleep in maybe for a half hour. It really was life-changing and hopefully something I can use forever. So that was a client that I saw August, most of August. Thank you.
All right, great, Jess. Thanks so much for that overview. So I'm sure there will be a few questions and discussion here. I have to say off the bat, I was pleasantly surprised by that couch eating analogy, because I think I have the same, but typically in my office, and then kind of like, I'm always so hungry every time I sit at my computer to work. So I think we can all relate to one of those. I saw one question there in the chat from Dr. Soparkar, who's a respirologist who is sleep trained that works with London Peak Sleep, and asking a very common and interesting question about your thoughts about virtual CBTI, such as shut-eye or Sleepio, and their efficacy in relation to in-person CBTI. Because to now, I mean, now you are doing some degree of virtual CBTI. It's obviously a little bit different, but yeah, I'd be curious to hear your thoughts.
Well, I don't know much about those two programs that you mentioned. I would love to hear more about them. I don't know if they are kind of self-driven
They
or
are.
the computer working with them versus an actual therapist.
So yeah, so typically both make use of online modules, and they're app based for primarily. Sleepio is a common one that I use, but Shut Eye is a similar. I believe it's from the group in Santa Monica with Dr. Marin. But yeah. So I mean, when you review the literature, Dr. Soparkar, the large scale reviews will say that in-person CBTI has a 10 to 15% improved efficacy over virtual CBTI. So I think that's to say virtual CBTI generally is effective, but it is more effective to have in-person CBTI, and most likely the effects there is due to keeping a person accountable, having somebody to keep you accountable, almost like working with a personal trainer. That's the analogy I always use myself as a gym guy. So.
Yes, I don't know much about those programs to say much, but I have had clients that have tried some, sort of virtually assisted programs, and maybe that was one of those was the program. And she just said, I just couldn't get out of bed. And I don't know how much they go into the rationale. And I feel like I really have to drive that point home to really get the compliance. And then with the compliance, they get the results. So, for me, I think it would be ideal to have somebody actually holding the person accountable each week. But, Dr. Wad definitely knows more about those programs.
Yeah, I mean, I've please guys unmute yourself as well for the discussion here. So feel free to chime in. I definitely don't want to be the only person chatting here, but my experience, I worked a little bit in particular with Sleepio, which is Sleep.io, which is probably the most popular that's out there. And my general consensus on them, they're good tools. However, they tend to be very generalized. So whereas it was interesting to hear you talk about cognitive restructuring, identifying catastrophic thoughts, that's very client and patient specific. Whereas these app-based CBTI programs tend to take a general approach. It'll ask you between 10 and 20 questions about your sleep, and then maneuver the program based on an algorithm to best suit you. But it's nowhere near as effective as on a session-to-session basis, identifying and changing the particular aspects of your care that need to be addressed from 1 week to the next. In my experience.
Yeah, absolutely. I mean, sleep is very individual and very personalized experience. And unless you are able to fully understand the client issues and in fact engage him and get him to invest, and I totally agree, they have to put effort and investment in addressing their issue, and there has to be some consequences for them, complying fully. You are not going to get optimal results for sure. I have a question, Jessica, regarding CPAP patient or who have developed patient with OSA who have not had necessarily serious sleeping problem but develop insomnia with the use of CPAP. Do you use the same approach, or do you have a different approach towards them, or what are your kind of feedback regarding those clients?
Yes, I have worked with a few clients around CPAP compliance, and just more specifically clients that have a little bit of the claustrophobia feeling.
Yep.
In particular, they seem to be the ones that have the most difficulty getting used to it. And a lot of times we just talk about exposure, and even just having the mask on just with their hand, just going from holding the mask for longer and longer periods, even not connected to the machine at first, and then just strapping the mask on, holding it maybe while you're watching TV, you're just in a calm place, you're just getting used to the feeling of the mask, and then eventually connecting it, kind of practicing having it, but being able to easily take it on and off, just growing more and more calm about the process of using it. And then maybe even trying napping a little bit with it during the day with the lights on, feeling, just lay down even for like a 20-minute nap, a 30-minute nap, just to get used to it, just to almost prove to them that they can sleep with it on and they're not going to die from wearing it, and that they can get used to it. Yeah. I find that approach, that gradual exposure, depending on the person, and just teaching them how to relax with the CPAP machine is, you know, one of the most useful.
Okay, thank you. Yeah.
Well, I did see a question from Amberly, who's a respiratory therapist who works in our Kitchener location. So she's asking about cost and are there programs for OHIP to pay for this? And that's a good question. Jess, do you want to run through general costs and your experience with insurance coverage? And then I'll chat a bit about how it works in our clinics for our clinicians.
Sure. Unfortunately, OHIP does not cover psychology treatment or psychological services. So usually my clients are paying out of pocket, and then I provide them with a receipt with my registration, just like, say, going to the dentist or other extended benefit providers. And then they are able to submit that if they have extended benefits for reimbursement, and if not, maybe holding on to the receipt for tax time to write off if they're self-employed. The cost is $225 per session. We usually take about 5 sessions, and I would say that's about the going rate. OHIP doesn't cover it unless maybe you're in a hospital setting or a research setting. I do believe Colleen Carney is looking in Toronto for people to participate for her CBTI research, and for sure reach out. And I think that's probably free treatment, which is great. Yeah.
So in terms of, you know, for our clinicians who face this, and obviously Jess has been with us now. Jess, you've been with us since 2019, and we've really run this through its paces. Jess typically works with, you know, roughly 5 or 6 clients, unique clients in every session. And so what we found is most patients have some degree of coverage through their insurance. So most insurance will provide some degree of benefits for psychological services. So that's helpful, and it's helpful to just let the client know that, or your patients know that. But when you're seeing your patients, whether they're primary insomnia or they're a comorbid insomnia and sleep apnea, I usually will run them through the basic of this. You know, what does sleep psychology involve? Why do I think it would be helpful in their case? And what is the evidence to suggest starting with CBTI over hypnotic medications? And then, you know, I let them know that it's not covered under OHIP, but that most insurance does cover some portion of it. And then from there, our offices really at all locations are really well versed in handling the rest. So they will administer to the patient a sleep diary. They'll administer a generalized sleep hygiene handout that we've reviewed and feel is appropriate and timely. And then they'll take care of booking the patient and managing any insurance claim or anything like that. So it's a very helpful resource for our physicians. And for me, it's been a world of a difference, instead of kind of, you know, having to prescribe long-term hypnotics, which has never really been my practice personally, and not something I'm fond of myself. And then Amberly also asked, you mentioned vitamin B acting as a stimulant for one of your patients. Does vitamin B typically act as a stimulant? I don't know if you want to take that. Anybody is interested in answering that with.
I mean, vitamin B is known to be an activator, and it's interesting that what Jessica mentioned about maybe taking it late at night can result in some sleep disturbances, but it is known to increase energy and to overstimulate the body and what have you. So it may be something to consider, that to take it first thing in the morning, which I normally do myself. And
B12 in particular.
Yeah, B12 in particular. Yeah.
B12, yes. Yes.
Yeah.
Yes. So I just wanna thank you very much, Jessica, for the great presentation. My name is Vivian. I can't turn on the camera because it's for some reason the presentation goes like the download goes very slow. But this is Vivian Ercoli. I practice in Mississauga, Kitchener, predominantly. It's a great presentation. Thank you. It's just interesting to see you highlighted the difference between the primary insomnia or independent insomnia and insomnia related to other psychiatric problems. It's not just the depression and anxiety. often ADHD and the bipolar disorder, like hypomanic phase, can present with early sign of decompensation can be insomnia or the sleep disruption. Even in my psychiatry practice, I always tell my patients, anxiety is probably the only disorder or only disease that we can actually cure in psychiatry. Everything else is just maintenance in the longer term, because we have the CPT, or in this case, the CPTI. It's a sort of a portable tool. You take it wherever you go. You can implement it without anybody else noticing. You can counteract your anxiety or panic feelings, and it's always useful to just generally utilize this tool to change your sort of your cognitive process or mindset and
Thank you so much.
behavior. So
If I might ask a question, and it's directed toward Jessica. First of all, thank you for your most informative presentation.
Thank you.
It was very helpful. My question is that despite CBTI being the first line therapy for chronic insomnia, there are some definite failures. I mean, can you give us some of the common reasons why the treatment might fail?
Sure. Well, if clients just have a really hard time getting out of bed when they're not able to sleep, they have a really hard time doing that. You know, the condition hyperarousal will persist. Also, clients, you know, commonly have difficulty sticking with the bedtime or the wake time. And then we really have to, you know, work on that, see if moving it to an earlier phase would be better for them. Then we will do that in the next session. But just trying to, you know, really reinforce the importance of that and adding that sleep pressure. Some people have pain issues and they find it more difficult to get in and out of bed, at which point we can use something called sleep compression, which is a little gentler form of sleep restriction, which might even allow them to just sit up in the bed. I know Colleen Carney was looking at some research with people with patients with bipolar disorder, and we're, you know, looking at how to do it more gentler approach, and they would just sit up in bed, turn on the light, get in a different, not a supine position, maybe even to sit on the other side of the bed, so that they're not in the same spot where they sleep, but they're not lying there in the dark feeling anxious. They're trying to get their mind off of it, and at least that may be better than nothing at all, really. Some clients do, especially clients with PTSD, may need, you know, a good amount of treatment for reducing their arousal related to their trauma before you introduce sleep restriction as well. And in some cases, we don't use sleep restriction at all. We might just focus on stimulus control and just letting them go to bed and wake up kind of at their desire, but just being really strict about stimulus control in terms of, well, not at their desire. We're just not, we're setting a bedtime and a wake time, but not in a restricted format, and just making sure they do get out of bed and they adhere to all the stimulus control rules. That's another way of kind of a workaround if someone's really having trouble with compliance. Also, I recently worked with a client, Dr. Watt is familiar with, who was kind of in denial that he had apnea, and he had been diagnosed several times with apnea. And he came in to do CBTI and then kept waking up in the middle of the night and not really knowing why. And I kept revisiting, you know, I revisited the fact that he was diagnosed with apnea, and he felt that, well, it turned out to be a good thing, because I told him about you, Dr. Viviano. And because he was very anti-CPAP machine, didn't really believe he had apnea, but in the end was not really benefiting a lot from the CBTI, because I feel like he was waking up all the time from his apnea, and he had kind of a dual diagnosis there. And so I believe he was more open and willing with the oral appliance, which has been a great resource for me as well.
Yeah, so this brings back this point about, you know, comorbid insomnia and sleep apnea, and we're not going to obviously go through the whole literature or anything like that, but I think an approach that we've started to take, Jess, which has been interesting, and I would encourage others to think about and you know, consider in your own practice, is looking at this approach of a combination of CBTI and CPAP. And that becomes the question of when do you start the CBTI and when do you start the CPAP for a patient who has features of both insomnia and sleep apnea. And the literature would suggest that up to 30% of patients who have sleep apnea may have some comorbid insomnia. And so, you know, when we look at it, what I have settled on for a lot of my patients is they have insomnia already. Let's just say initial insomnia. You put a CPAP mask on, that's probably going to exacerbate the issue. And I think Dr. Shapiro was talking about this last week. So generally what I've done with these patients is I let them get through their first 2 sessions of CBTI with under Jessica's guidance, which, as she mentioned, it introduces them to the major concepts. And then we add on say CPAP therapy, oral appliance, or what have you, as they go through the remainder of those 3 sessions. I think so far we've had, you know, limited numbers, but good success with that approach. So I'm curious if anybody else has had similar experiences with those patients.
Yeah, absolutely. It's very important to know that there's lots of support or a strong relationship about early adjustment to CPAP and long-term utilization. The first 6 to 8 weeks are crucial. So the early intervention, if there's any evidence of problem, to try and resolve it and not to introduce negative conditioning or what have you, from my experience, are the best approach.
And it's not the only way. I mean, you know, other people talk about a short-term trial of hypnotics as well, which, you know, is something else. I don't know, Dr. Soparkar or Dr. Saxena, Dr. Okoli, have you trialed those approaches, found success or failures? You know, how has that been for you?
Well, a small number of patients we have, but even if I use hypnotics, I try to, you know, steer them away from the prescription ones. I mean, my advice would be, you know, just try over-the-counter melatonin or something, which would, in my view, would be a safer approach rather than, you know, getting them on a prescription medication. And I've had good success with melatonin. I can't say the same with any other medication.
I'm sure it's a placebo effect because, you know, melatonin really, it takes about 3 to 6 months to work. But, you know, I mean, the placebo effect in some of those patients can be very strong as well.
I have seen many cases where the initial sleep study highlights coexistence of possible insomnia, initial or sleep maintenance insomnia, and severe sleep apnea. I often don't perceive that I have enough before I offer the CPAP. So I often prescribe very brief use of a safe hypnotics like a zopiclone, at least for the purpose of the titration night. And then gradually we can work on like just to elicit the benefit of the CPAP and convince the patient that it will be a useful tool in the longer run. And then we can address the insomnia in a lot more detailed sort of comprehensive approach later. So it depends on the patient's presentation, the severity of the condition.
I definitely support, you know, Vivian, and that what I did for, you know, many years, and I have had good results using zopiclone on trials and sometimes short term. You know, however, as of late, you become a little bit more cautious, you know, with giving a prescription and worrying about, you know, potential dependency or, you know, side effect or what have you. But definitely that approach worked for me as well for many years.
Thank you, Awad.
You know, it's true. It's true.
I mean, you're one of our longest practicing respirologists as well. I'm curious your experience as well. I think we might have you muted there. Well, if I'm not sure if we're able to get Dr. Saxena on, but on another topic, while he does.
Hi, I'm here now.
Great, there we go. Nice.
Yeah, so my opinion is kind of a blending between Dr. Soparkar and Dr. Okoli. If patients who have a lot of anxiety about CPAP, I will speak to them about it, who have sleep apnea and why they're anxious about it. And, you know, obviously work with some of the RTs and try to get them comfortable. But if they're still having anxiety issues, I kind of will talk to the patient. Some prefer the natural approach, so I will use melatonin. Others, I say, look, let's try a 1 week to cool you down on a hypnotic, and we go from there. I think now from this lecture, what I'm going to think about is perhaps adding CBT as one of those 3 options now as a possibility. depending on the patient's point of view and perception.
Thanks, Kash. Helpful. I was going to ask you just one other thing that I've tended to do when I'm referring patients on to you and they are very much treatment naive. I may ask them as they're kind of waiting to get into cycle to trial melatonin at a reasonable dose of 5 milligrams, which we know is sort of most stimulating for these purposes. So I'll usually have them do that for 6 weeks as they're initiating CBTI. But I'm curious, is that something that you find actually hinders your progress or your treatment?
I haven't found that it hinders it. When I was, the old school of thought was that they should be off their sleeping pills when they start CBTI, just so that you can get a really clear picture of their sleep architecture as well, so they don't give the sleeping pill too much credit, and instead they're giving the credit to the hard work they're doing in therapy. But I still see quite a few patients coming in on something, and I tell them, I'm not a medical doctor, but you should ask your doctor if they could give you kind of a schedule for weaning during the treatment, because while they have my support and while we're utilizing the sleep restriction, to have sort of a plan to wean down. And so most of my clients go back to their physician and they ask, what's the best way to do this safely to come down, in a gradual format during CBTI. That's not, I see that all the time. A lot of people have a really hard time stopping their sleeping pills though after they start them. So I'd say that's one of the hardest things, is just convincing them, instead of giving the credit to the sleeping pill, especially when they're just taking them PRN and they have 2 or 3 bad nights with CBTI, and I just know they would sleep like a baby on that 4th night, but they break down and take the sleeping pill instead. And so they say, I finally slept, but that was probably because of the sleeping pill. And I'm like, no, it was probably because you've restricted yourself so much and your pressure was built up and positive conditioning is coming. But if they have that bottle in the other room, they're like, I'll just take the pill. I know I can sleep then. And so it's something we work around, but I always refer them back to their physician. So if you are sending somebody in, you may talk to them, you can take it at this level. And then if you want to gradually come off of it, this is the best way to do it. Then they kind of know how to do that. Or maybe they can ask their pharmacist.
Great. We have time for one more question if anybody is interested, but otherwise, Jess, thank you so much for your time and helping to educate me. And I trust everybody else on this black box in sleep medicine that I think so many of us have had interest in for a long time.
Well, thank you. I appreciate the audience showing up right before Christmas on a Monday night. I'm excited to say this is the last thing I have to do, and now I have 2 weeks off, so that's exciting. I hope you all have
Same everywhere.
holiday.
Yeah.
Thank you so much, Jessica. It was